Dear listeners, welcome to Faces of Digital Health, a podcast about digital health and how healthcare systems adopt technologies. I am your host, Tjasa Zajc, and this is the second part of a short series about AI in healthcare. In the previous episode, you could listen to my thinking about how AI could potentially bring better equality between the sick and the healthy. In the future episodes, you'll be able to hear about the potential of AI in diabetology, stroke research, and more, so do subscribe to the podcast so you don't miss those shows. But today, we're going to the most hyped AI application in healthcare, radiology. The idea that AI will replace radiologists comes from the fact that today's AI models are very good at pattern recognition. But in reality, the rich data coming from radiologists is in the radiology reports, which are to a large extent unstructured. As elsewhere, the 80-20 rule applies here, says Woojin Kim, today's speaker of the show. So the interesting thing in radiology are the natural language processing models mining radiology reports. If you're wondering what radiologists do, what are they going to do in the future, are they going to start talking to patients more, why they will not be obsolete anytime soon, do listen further. You will hear from Woojin Kim, the Chief Medical Information Officer at Nuance, who in the past worked as the Chief of Radiography Modality, Director of Center for Translational Imaging Informatics, Associate Director of Imaging Informatics, and he was also an Assistant Professor of Radiology at the Hospital of the University of Pennsylvania. He's also an entrepreneur who founded his own company, Montage Healthcare Solutions, which was later acquired by Nuance. Woojin, let's start with a very general question. The public perception of radiology is that radiologists only sit in basements all days looking at pictures. So what is the reality? What other assignments do you have as a professional in radiology?
Considering that many radiology departments are located in basements, I guess I can understand the general perception that you just described. While it is true that radiologists in general do spend a lot of time looking at medical images like X-rays, CT, MRI, ultrasound, and other imaging types, and render their interpretations of them, it is important to keep in mind that radiologists do more than simply look at pictures. Radiologists play an important role in every aspect of medical imaging, from when an exam gets ordered, to perform, to interpret it, to finally being delivered. For example, radiologists often guide the ordering clinicians on what exams to order for the conditions that they're evaluating. Some are pretty straightforward for many clinicians, like, order a head CT without contrast to look for a head bleed, but order an MRI with contrast to look for a brain tumor. But a lot of the exams are not so straightforward, and radiologists do spend time assisting with that particular process. And related, radiologists help to protocol exams as well. And beyond interpretation, they often explain findings to their clinician colleagues and communicate important findings directly as well. So I wanted to also say that many radiologists also perform procedures. I'm a musculoskeletal radiologist, and I used to perform image-guided biopsies and injection of joints. So I've done, different types of procedures. And that's when you actually have more patient interactions during those times as well. And these are just a small sample of activities radiologists perform beyond just looking at pictures in dark rooms.
If we stay a little bit further with the complexity of radiology as a specialty, how diverse are the profiles of radiologists in the field? For example, do you further specialize for a specific area. You yourself mentioned that you were a musculoskeletal expert.
I can tell you how a typical radiologist gets his or her training. So in the United States, now every country is a little different, but in the United States, you go to 4-year college, right? And after you're done with college and get your, bachelor degree, then you actually have to take an exam and apply for a medical school separately. I know in many countries that the undergrad and medical school training is combined into such as, like a 6-year program. But in the United States, typical pattern is that, a college student, graduates from college, applies to medical student, and gets into a 4-year medical school. During the 4-year medical school training, that's when they start to figure out what they want to do with their lives. And let's say, you decide to become a radiologist, and again, not, every program is the same, but the typical classic pathway is, after the 4 years of medical school, then you have to apply for internship plus a radiology residency. And that's a combined 5-year program. And after about 5 years, then, you can come out and you would be graduating a diagnostic, say, radiology residency, and you become a radiologist. But at that time, then you're considered to be a quote unquote general radiologist, meaning that, you are able to read, many different types of imaging studies. Now, someone like myself, then what happens is you actually, after the residency, you do another year of fellowship. The fellowship could be as short as 1 year, it could be as long as 3 years, depending on the specialty. And that's where you pick a particular area that you're interested in. For me, it was musculoskeletal in the area of orthopedics. You could be specializing in the brain as a neuroradiologist. That's typically 1 to 2 years fellowship. You can specialize just in the body or the chest or the cardiovascular. So there are different, areas of expertise that you can get into. And after that 1 to 2 to 3 years of fellowship, then you come out as a specialized radiologist. So you can imagine that the training process is extremely long, about 10 years of extra training before you become a specialized radiologist.
There's been a lot of hype around AI and radiology. I think radiology and dermatology were one of the first fields that got marked as the medical specialties that are going to be replaced by AI. So one thing that I want to know here is your brief comment on this. I think it has become clear by today that this is of course not true, that AI will complement the work of radiologists. So where do you see the biggest potentials? What's your comment on the whole hype?
I think a lot of this began back in 2012 with the use of deep learning through a convolutional neural network of AlexNet back in 2012 that won the ImageNet Large-Scale Visual Recognition Challenge. There has been an explosion of interest and advancement in computer vision to hype up AI replacing physicians like radiologists. In fact, in 2016, Geoffrey Hinton, who has been called the godfather of deep learning and also a part of that AlexNet I just described, said, quote, people should stop training radiologists now. As he predicted radiologists being replaced by AI in 5, if not 10 years. And many other AI experts have said similar things. It wasn't just Geoffrey Hinton. And on the surface, it is understandable where this type of thinking process is coming from, right? By 2015, the computer algorithms were doing better than humans at object detection and image classification tasks of the ImageNet challenge I just described. The AI experts naturally assumed that, hey, you know what? They can translate that into medical imaging and thus replace physicians like radiologists. In 2019, I can tell you, however, that very few people, even Geoffrey Hinton, talk about AI replacing radiologists, kind of like what you mentioned. And the reason is because radiologists do not only interpret images like how I described at the very beginning of this, conversation with you. But what I wanted to say is, imagine, just giving a slightly different example, imagine if I, someone who is single without children, said I created a robot that can feed babies and change their diapers. I then go on to say, hey, you know what? These robots will replace all mothers. You guys will think either I'm crazy, an idiot, or both, right? Sure, these robots can assist mothers, but cannot replace mothers just because they can do 2 tasks for babies, right? And what I can tell you as a radiologist is that not only do we do more than interpret images, but even when you look at image interpretations only, that aspect only, there are so many different things we look for other than lung nodules and breast cancers when it comes to radiology. So for example, when you look at a lot of the AI models that are out there that are making headlines, you see a lot of them saying, things like, hey, you know what, this AI model, was able to detect breast cancers as well or better than radiologists or faster than radiologists. But I can tell you, when I look at a particular image, I'm not looking at just one thing. I'm looking at literally hundreds, if not thousands of different possible things that could be present on an image. Today, the AI is very narrow. People talk about narrow AI. They only focus on one thing, one finding on one modality, meaning like on an X-ray or on a CT or an MRI. So there's a lot of limitations, which means that if you want to really replace radiologists just in the image interpretation part, today you would need literally thousands, if not tens of thousands of models, which we do not have. Okay. And taking that aside, I mean, one of the things that a lot of people don't realize, even the AI experts in general, is that AI has a ton of challenges to overcome before they can be widely used in healthcare, because healthcare is very, unique in its own set of challenges when it comes to translating AI from, say, research into actual clinical practice.
2 things there. One is, what kind of AI assistants are so actually used in clinical practice? Because a lot of the things that we read in the media are experimental things, retrospective studies. So I'm curious to hear what's already used in practice. And the second thing was that you mentioned how the AI models are narrow. So does that mean that, for example, different developers are only working on an AI algorithm that detects lung cancer, and then you're going to have another one that's going to be working on breast cancer? So basically, there's hundreds of teams that are working on very, very specific topics. So all of that would have to be combined, and we're still far from that. Is that right?
So I'll take the second part first. As far as the narrowness of the AI, yes. Today, the AI models that you read about in papers, for example, are, let's say, let's just take the example of lung nodule, right? You can take a lung nodule detection algorithm or model that works on X-ray, and then you feed it an image of a CAT scan of the chest and expect to do the same thing. You're looking for the same finding, i.e. lung nodule, but the images are completely different. So this is why this is so different than, say, hey, I know how to make an AI model that can, predict the picture of a dog versus a cat with 99.99% accuracy. Well, that sounds great, but doesn't mean you can you translate that same thing and then expect to work in medical imaging by just supplying an image of an X-ray or image of an MRI and a CAT scan. They're very, very, very different. Even though they're looking for the same thing, let's say lung nodule, it's not quite it's the models today are so narrow that they're only looking for a single finding on a single imaging modality. And now, when I say imaging modality, I'm referring to things like X-ray, CT, MRI. Those are all considered, imaging modality. And right now, they only look at one thing on a single imaging modality. So they're extremely narrow, which means you're right today, as of now. You can create a multiple different algorithms that work together to be able to detect, lung nodule on a CAT scan, MRI, and CT, and then all those other modalities. But in reality, you have to train them all separately, and then you have to create the algorithm separately. So on the surface, they might work as if, you can potentially create an AI model that works on, multiple modalities, but in reality, in the back end, you are creating essentially individual algorithms for every single one of them. So,
but is it just a little follow-up question here? Aren't generative adversarial networks and transfer learning exactly aiming to solve that? Kind of connecting all the areas that are currently still in their beginning stages.
Yeah, so the GANs that you talked about is the, people are using in medical imaging slightly differently. They're using it to augment data. So here's the other challenge in medical imaging, right? So yes, you can easily Google for, 200,000 images of dogs and, same number of cats, and then feed it into an AI algorithm, and then let it train, right? So that's fine. And deep learning requires a tremendous amount of data. But there are certain diseases that we get to train to learn to recognize during our training. And as humans, I don't need to see 5,000 examples of it, right? I just need to know that that particular disease exists. It's extremely rare, but I do know what it looks like by looking at a handful of examples, say from a textbook. AI models can't do that. They can't learn by showing, 5 examples of this super rare disease and expect to learn it. So what people try to do is they use GAN technology to simulate diseases in different environments to train these algorithms to augment the data so that you have more data than you really have by using GAN to create these fake images, right? That's good enough to fool the human eyes and able to increase the accuracy of the AI models, and they do work in terms of improving AI models. But I'll be honest, the first I'm one of those people who are extremely skeptical of using GAN, for example, to augment imaging data sets to train it. Granted, they are, improving the accuracy, but one of the things that also is very challenging for AI in medical imaging is that the AI models are extremely brittle. Meaning that, let's say I created a model that, does the pneumonia detection on chest x-rays using, say, hospital A's data, and it does really well because it was trained on it, and it does extremely well. So I show a new chest x-ray from hospital A. Hey, if there's a pneumonia, it detects it. Great, I'm very happy. I take the exact same model and I take it to hospital B. Guess what? The model does not necessarily work as well. And this is a phenomenon, that's been described as the brittleness of AI models. And we have seen this in research settings. For example, at the end of last year, there was a paper where folks from Mount Sinai looked at just like the exact same description that I just gave you, which was the chest X-ray pneumonia detection AI model. It really worked well within that hospital data set that it was trained on. But as soon as it took an external data from a different hospital, the model started to fail. People are starting to become familiar with this problem, but we haven't seen it out in the wild as much, and hence not on the newspaper articles, just because AI models are not being widely used in clinical practice as of today. But when they do, this is one of the challenges that everybody will have to deal with.
Why does this occur actually? Because, from the patient perspective, it's hard to understand why if you went to get an X-ray to one institution and then go to do an X-ray to a different institution, how could there be a change if unless they used different machines and the machines had a different accuracy. So
that's a great question because a lot of things that I say, I think for certain AI experts or those people in medical imaging, that's like, oh, okay, I can see it. But from a layperson perspective, your line of questioning is perfectly reasonable because you're right. When I get an X-ray from hospital A and a chest X-ray from hospital B, when I look at it, they look pretty much the same to me, right? I get one today and then another one tomorrow from two different hospitals. I look by side and I probably won't be able to tell the difference. And for me as a radiologist, same thing too. But here's the thing. With AI, it's a little bit different. AI is very sensitive to the data that is trained on. And believe it or not, depending on how the exam was protocoled, how it was obtained, what scanner it was done, whether it was done on a GE machine versus a Siemens machine, these things do matter to the AI. They're sensitive to these things. So that if I were to say, train a whole bunch of models on, one manufacturer on one set of protocols, and then tomorrow I decide to buy a new one, completely different vendor, different protocol, image is the same, chest X-ray. I can tell you there's a decent chance that the model that used to work really well won't work starting tomorrow. And so this is the kind of thing that we know that exists out there. We've seen it in research setting nowadays, and people are starting to talk about brittleness. And hence what's happening is that now people are more aware of this. So people in AI, in medical imaging are now saying, hey, you know what? We need a greater variety in terms of data sets that we train these things on, number one. And number two, we need to always validate this. Just because the vendor says, hey, you know what, we just created an algorithm that functions, that works at 99% accuracy. Well, guess what? Just because you buy it and you place it in your hospital, it might not quite work at 99% accuracy. So you have to validate it using your own data. And this is all comes from the fact that, answering your original question, it all comes from the fact that the modern day machine learning and deep learning really depends heavily on the data that they were trained on. And these are the challenges why, answering your other question, which is, what kind of AI is being used in clinical practice every single day? I can tell you there are not very many. Right now, a lot of them are in research phase still or piloting phase, and people are testing it out, playing with it, trying it out and stuff like that. But, it is not something that is, widely spread as of yet.
But so you mentioned that the problem might be in different machines that hospitals use and the changes in the data set. But surely companies are already trying to develop models gathered from different institutions and different machines. What does that mean? That you get a really confusing outcome if you just mix everything together?
People have looked at other different techniques to improve the accuracy of these models by, one of the other things you have to think about is, at least in the US, hospital data, patient data is very sensitive. We have, the HIPAA rules and other things where, it makes it very difficult to get access to patient data. But you need a lot of data to train your AI models, right? So these startups, one of the challenges that they're facing in healthcare is getting access to data, first of all, from a volume perspective. And then the other challenge is to get them all labeled, which is quite labor intensive when it comes to radiology. Because of the brittleness, you ideally want to get data from multiple different manufacturers, for example, right? And there are different ways to do this. I mean, sure, you can create a central data repository, although most hospitals won't allow you to put their data in some central repository elsewhere just so that you can train your AI models. But the other options are, things like federated learning, right? Where, that's another technique where your data resides where you are, just only the algorithm moves around. And so you can potentially train your model on multiple different data sets without actually without the data actually leaving the local site. So there are different techniques to allow for these kinds of things. We're seeing better improvement in terms of AI models with these techniques. So these challenges are not insurmountable. It's just that you have to be aware that in healthcare, you just have to deal with these kinds of challenges. Now, speaking about this also is that one of the things I can tell you, I'm glad when I go to AI conferences now in medical imaging, people do start talking about the brittleness of AI models, which a lot of people didn't until recently. Now, one of the things they are yet not talking about as much is something called the concept drift. And I don't know if you're familiar with that terminology, but the idea of concept drift is the following. Let's say, the AI model actually does work really well on hospital B, okay? Now, what's going to happen a lot of times is over time, that model will start to degrade in its performance.
Why?
Yeah, that's a good question. So that is called the concept drift. And the reason why is, remember what I told you, that AI models are very sensitive to data, right? Which means that if there's a change in the data that it is seeing, that it is trying to predict or make a diagnosis on, then the model will start to quote unquote fail because it is now looking at a different set of data. And why does that occur? Well, that occurs because in a hospital, like I told you, for example, on day one at the hospital B that I got this model is working really great. And then, 3 months down the line, I decided to change the protocol a little bit. I decided to get it slightly, increase the sharpness of the image, or, I decided to do a software upgrade, and then the image is by the manufacturer. So that changed the data a little bit. And then, another, 6 months down the line, I decided, actually, I just saw this new, scanner. I'm gonna upgrade to this brand new scanner. Not even a software upgrade, but an actual, a machine upgrade. Or even worse, or better, let's just say, hey, I'm gonna go with a completely different vendor this time, manufacturer. So you do all these, changes, and that changed this data over time. And that's the concept of the data drift that happens. The AI model has not been retrained on all these new data as it goes. It's just still the same model that I purchased on day one. And so it is going to perform differently. And a lot of times it will perform worse over time because there has been change in the data that I'm getting. Now, the AI companies don't get every update, right? They're not going to get an email from the hospital B saying, hey, by the way, we just upgraded the software. Or, hey, we decided to buy a new X-ray scanner. No, there's no communication like that between them. So the AI companies, it's the responsibility of the AI companies to constantly monitor the AI performance and then notice as soon as there's a degradation in the performance that, hey, something happened. I don't know what happened, but we need to figure it out.
How can companies even ensure that all the monitoring is going on so they know that their models are still up to date? And at the same time, if this can happen, what you just described, how can medical professionals work in peace and in an assurance that the recommendations that they're getting are accurate? How can you even rely on the support systems that you get if they're so fragile in a way?
They can be considered fragile. That's one way to look at it. But taking the optimism perspective, the reason I highlight these potential challenges is that so you are aware of it, right? But none of these challenges are so, impossible. So let's just take the concept drift example, for example. That this is a potential possibility using AI models in a clinical practice. Knowing that, what would you do as a company? Well, you should figure out a way to get feedback from the users, whether it's a proactive, but you shouldn't really rely on that too much because physicians are extremely busy, so they're not gonna take their time from their busy clinical practice just to tell an AI company what they think about it. What they'll do is, if it works, they'll continue to use it. If it doesn't work, they'll just shut it up. In the back end, you should have a mechanism where you're constantly monitoring not only the interactions of how the radiologists, let's use the radiologist example, interact with the AI models on a daily basis, but also have a mechanism to constantly look at the accuracy of your model. AI companies by themselves can't do this, unfortunately. They need to partner with other companies that provide other workflow solutions. So, for example, I work for Nuance, as a full disclosure. I'm a Chief Medical Information Officer there. And Nuance has this, reporting application that the radiologists use using voice recognition, speech recognition to create their radiology reports. In the United States, a good majority, more than 3 out of 4 radiologists in the United States use Nuance products to generate radiology reports. And one of the things that we've been working on is to create a marketplace where, hey, you know what, you're an AI company, you can upload your AI model to the marketplace. And in return, one of the incentives that we can provide for you is the radiologists are going to put it into the radiology reports, what they're going to do with your AI output. One of those 3 actions, that's going to make it into the radiology reports. And what we can do is we can send that feedback back to your AI company, to your AI model saying, hey, you know what? This is what the radiologist actually did with your output. That way you get feedback. So you need to integrate your AI solution, which is another very important topic, into the existing workflow of the radiologist so they are not interrupted by AI, but they're seamless integrated. So I'm just interacting with it within my existing workflow. So which means you need to kind of partner, integrate with the existing workflow to get that kind of feedback. The other thing is, before I joined Nuance, I had a startup called Montage Healthcare Solutions, which I sold to Nuance. And then that's how I became, part of Nuance as their CMIO. And that Montage is really the easiest way to describe it is almost like a Google for radiologists. It allows data mining and analytics of the free text, the radiology report text. Well, one of the things I said earlier was I don't know if the model that works well in hospital A works just as well in hospital B, right? So imagine instead of just buying it, the AI model at hospital B and turning it on and crossing your fingers that it will work, what if I say, hey, you know what? What if I can tell you, okay, you just bought a pneumonia algorithm. I'm going to look at your past, radiology records, your images and report. I'm going to pick out 100 positive cases of pneumothorax on chest x-ray, 100 totally negative normal chest x-rays. I'm going to pick those 200 cases and I'm going to just feed it into the AI model that you just purchased for hospital B. And then get statistics based on your own data. That way you get to know before you even turn it on whether this thing is even going to work at your site or has the potential to work at your site. And that's one of the things that we're working on as well, because Montage was designed to mine the radiology reports, and now it's called Empower actually under Nuance. So using that same technology, just getting the cohort of data that can be fed into the AI model for validation before you even start using it, right? So these are just some of the things that people can do in healthcare to really help adoption of AI models into the clinical practice, and then also deal with some of these challenges that I talked about.
In radiology, everybody focuses on images, and this is where the ideas about AI replacing radiologists comes from. But this is a key point that you mentioned, which is the meaning and the importance of radiology reports. So maybe a word or two about the use of radiology reports in designing AI models, and how structured are these reports actually, and how much are they still written in the free text?
Just like in any other fields out there, the rough estimate is that the classic 80-20 rule, where 80% of the data that's out there is unstructured. And same thing in radiology and healthcare. But if you look at a lot of the analytics, they look at structured data, which is only about 20% or even less. Traditionally it's because, it's been very difficult to mine that unstructured data. But there are solutions that are out there, including, natural language processing, now supplemented by a lot of the latest AI techniques. That's really, really bringing great advancements in being able to analyze the unstructured data. Now, answering your question about the radiology reports, you typically hear, structured radiology reports versus unstructured. When people talk about structured radiology reports, a lot of times they're not really structured. Now, I know in Europe they use some people use these software that allow you to use multiple drop-down menus to create a truly quote-unquote structured report. But most radiologists do not like to use that kind of interface. They don't have time to do, 50 different clicks and drop-downs to generate a radiology report. That's just not how they work. And they like to speak into the computer or to a tape recorder and then generate their reports. So a lot of people, when they say structured report, oftentimes it's a report that a template, right? So, for example, lungs, colon, no clear lungs, for example, or, 2-millimeter lung nodule. But they're not really structured from a data perspective because they're just templated. So, from a human's eye, it may look like they're structured, but in the database, they all get stored in the same way as just a prose report, right? They get stored as one long string of text. So, having said that, how can AI be used is that, going back, NLP, traditional NLP techniques have been used to analyze these reports. But latest advancements in, things like GPT-2, BERT, Elmo, Clover, and using these kinds of techniques, you can do a lot more advanced, analytics of it. Radiology reports are, one of the main products of radiologists. And they contain the interpretation. And if you can leverage that information, you can actually improve your AI models. And in fact, some people have done just that, which is, they decided to use radiology reports as quote unquote weak labels to label these medical images. Remember, I told you earlier that, drawing these little, region of interest on every single image where the radiologist thought there was a tumor, just to train the AI models is extremely time-consuming process. But people, for example, at Stanford have shown that, by leveraging the radiology reports that contain the findings within images, using that to weakly label the images, you can actually create pretty decent AI models. You need a little bit more than just imaging pixel data in terms of volume to train the AI models to the same level of accuracy, but you can use these kinds of techniques. And, you can use these techniques for validation purposes and other things. So people have used, AI techniques to do great things with the radiology reports. Things like, for example, lately there's been a number of articles looking at using AI to find if there's a follow-up recommendation in radiology reports. So, roughly 1 out of 10 times a radiologist looks at an imaging study and will make a recommendation saying that, hey, you know what, I think I see something here, or I definitely see something here, and I need to follow this up. I need to have this person come back for another study, another exam 6 months from now. The unfortunate thing is a lot of these patients don't come back 6 months from today. So, despite the recommendation. And so people are using AI to first, find that recommendation within radiology reports and then be able to track the patient and to make sure that patient comes back. So these are, sure, these might not be the quote unquote, the sexy use cases of the AI in radiology, but these are very, very important and have a great level of impact on patient care. Yeah, that's another area.
Everything that you described about the use of AI in radiology shows that the field is changing relatively slowly. So radiologists' work is changing slowly. But one of the discussions that is coming up when we're talking about the introduction of technologies in radiology is, are radiologists going to need to spend more time with patients? And there's a discussion among radiologists about the fact that this might not be the best idea because radiologists, if they do have a contact with someone, it's the primary care physician or the physician that's taking care of the patient. So where do you stand on in this debate? What's your opinion?
The reality is that some radiologists won't speak more to patients even if they have more time today. Okay, some predict even the opposite. That AI will speed up the imaging so much. For example, there are AI techniques that we haven't discussed, but there are AI techniques that are out there that will make, say, MRI scanning time to be in a matter of minutes instead of, say, 30 or 45 minutes, right? Because AI will speed up the imaging so much that we as radiologists will be even busier as there will be more studies to read, which may even worsen our burnout instead of helping. So there are different, predictions about, AI. So it's not all about, hey, AI is gonna, really, make us so much, do so much of our work that we're gonna have so much free time. Therefore, we should spend that time talking to patients. Only time will tell what will actually happen in what sequence. One thing for sure, as AI advances and makes real improvements, we as radiologists will need to change, which may include greater interactions with our patients and greater role in clinical care. Now, the optimist in me believes AI will make things better. However, you cannot ignore the negative role things like greed can play in healthcare. So speaking about the primary care aspect that you talked about, I don't think the argument about speaking with patients more is for replacing the primary care physician's role. In fact, it is more about increasing contact to allow greater awareness for the patients of their imaging findings. And the increased contact with patients should really coincide with greater contact and collaboration with the other providers in the patient's overall care. So not independent of, hey, you know what, primary care guys, you know what, don't worry about the imaging findings and just gonna talk to the patients. It really shouldn't be taking certain roles away from a primary care physician, but it's more, hey, you know what, I'm gonna actually spend time to describe these things to the patients, but in conjunction with greater same level of increased communications with the primary care physicians. One of the things you have to think about also is that primary care physicians may become busier with AI. And they may not even have time to speak with the radiologist. So it really has to be a balance. And, if there's an imbalance, it really won't help just because radiologist wants to talk to the patients more often. And the other thing is that, one of the criticism I think people talk about is, hey, you know what, the radiologists don't know the full history of the patients. And some of that is the fault of the ordering provider, and some of that is the fault of the EMR and its design. However, the information is there, especially if you have EMR. And if AI can assist with an accurate summary of the patient, then radiologists can provide greater value to the patient and other providers by better synthesizing the interpretation, by incorporating better medical history. It is well known that radiologists often get very poor history, and I can tell you from my personal experience, when we're reviewing or when they're reviewing images. They also do not have the time to dig through the EMR. Some don't even have access to get that information. And all of this negatively impacts the interpretation. Said the other way, we know that the better history we have, the better and more accurate interpretations we can make as radiologists. I remember when I was, one time, I remember talking to an ED physician and I say, hey, you know what, you need to give me a little bit better history. And he says, everything you need to know is right in front of you in the pictures. And I'm like, no, that is not true. Okay. So for example, if you come into the ED and you did stub your toe and you think you have a pain in your fifth toe, and the ED doc thinks, you may have broken your fifth toe. Guess what? If you don't tell the radiologist that you have pain in your fifth toe, there's a chance, unless it's a really, really badly broken toe, that small fracture line might not be detected by the radiologist. But the same imaging study, same radiologist, if you say the pain is on the fifth toe, then the radiologist has a much better chance of finding that. And it is nothing to do with the competency level of the radiologist. it is the importance. That's just to highlight the importance of clinical history. And unfortunately, a lot of times we just get like pain or, foot as the history. And that doesn't do me any good. So these are the things where the history becomes important. I'm going a little sidetracked, but the argument about us speaking more with patients, yes, I mean there is a definite benefit to that, but there are other considerations to take into effect.
Was it always like this, that radiologists didn't speak to the patients, but they just got a little bit of their medical history and the image? Or was it ever in the history of radiology that you would first talk to the patient to detect issues as you described, and then do an imaging and then get an interpretation out of it?
Historically, it was more with the clinicians. So, for example, I remember when I was training, we would just go over the, cases from last night. I'll be, going them over with an attending, let's say, as a resident. And then during the review process, what happens is a group of the other physicians, like let's say a group of internal medicine doctors would come down with their residents and interns, right? They all come down to the reading room and say, hey, you know what? Can I go over patient this and patient B, patient C, patient D? And then we would actually have an active discussion. So the attending would say, hey, you know what? This patient came in with a fever of this. And, I'm thinking, the patient might have a pneumonia in the right lower lobe, because I'm hearing these, sounds on the stethoscope and blah, blah, blah. And then I bring up that image, or the attending will bring up that image and say, yes, you know what? You see this opacity right here? Yes, that's the pneumonia in the right lower lobe. It goes with the history. Yes, this is not XYZ. This is pneumonia based on your clinical suspicion and so forth. So I learn from them, and then they learn from me. So there was more interaction there. Now, fast forward to today, that stuff doesn't really happen. What happens is everybody's so busy and everything's so digitized, so that I look at the images. I think this is a pneumonia. It could be something else, but I think this is most likely pneumonia. I put that in the report. I sign it off. That report gets digitized, sends to the medical records, and the internal medicine folks, what they do is they just look it up in the morning on the computer. So it's been decreasing communication. Now with AI, maybe we'll have time to do that again. Who knows? That'll be good. And that's something that I miss about the old days, in terms of how we used to practice, and we used to have more collaboration, because, we all learn from each other when we have that kind of thing. And I can be better at my interpretation, and they'll be more confident in their treatment and their diagnosis as well. So that kind of communication definitely has gone down over time. As far as the patients, radiologists, when they do procedures, they obviously talk to patients. That always happens. And in mammography and women's imaging, they always talk to patients. So that's always been the case. So it's not that the radiologists never talk to patients. It's just that certain areas, some radiologists do speak more with patients than others.
To your point regarding the doctors and the decreased level of communication and collaboration today because of technology, I think one of the things that have become clear with the introduction of electronic healthcare records is the need to pay more attention to the usability and the UX of solutions, which, if we are optimistic, are going to be designed better with AI than they were with EHRs.
The hope is that the AI will definitely improve the usability and the kind of information we can get from EMR, our interactions with them, and then also what kind of information it can actually feed back to us, right? I see some promises in some of those using AI for medical record. For example, I can give you an example of conversational AI from actually Nuance, where they, in recent years, they demonstrated using conversational AI to do the following. So one of the main criticism of digitization and use of EMR is that patients see the back of the physician's heads as they're typing. They no longer see them, their eyes as they're, looking at you and talking to them face to face. Instead, the physician is looking at the computer screen and typing what the physician and what the patient is saying, right? And one of the use cases of conversational AI is the following. AI will listen to the conversation that's happening between the physician and the patient. And then instead of just purely transcribing that entire interaction like a movie script, what it will do is it will pick out certain elements. And then, let's say the patient comes in with the right knee pain and then describes the pain, and the physician examines her knee and then finds all these, the findings, and then makes a diagnosis of osteoarthritis and makes a recommendation for certain medications to be sent out to the pharmacy. All that information gets extracted and then placed in right places in the medical record. And that's the dream for many, many physicians, right? Where I just talk and then a computer actually does all the note taking and summarization, and even sending the prescription to the pharmacist all on its own. And that's where I hope the AI will help. It will change the UX, the UI, and then also really help us to have a more human-to-human interactions as a physician with our patients, and less time actually transcribing. Because most doctors will tell you they did not go to 10 plus years of medical training just so that they would be a data entry person. But unfortunately, that's what the EMRs are today. And hopefully AI will change that. Obviously the challenges is that a lot of the EMRs are extremely old in terms of technology. If you look at some of the EMR screenshots today, I think you'll be shocked. I think you'll be kind of shocked as to, hey, you know what, I can't believe this is what people pay millions, if not billions of dollars to install in their hospitals, and this is how doctors interact with this particular software to enter data and to get data out, or not be able to get the data out. So there's a lot of technical limitations, but I think even given that, I think AI does have a potential to really improve the interactions.
You've been listening to Faces of Digital Health. Next week, the topic will be the development of artificial pancreas and the potential of AI in diabetology with Dr. Tadej Batelino, Head of Endocrinology Department at the Children's Hospital Ljubljana and Chief Clinical of Dream Diabetes Decision Support System. Stay tuned.